Well, good morning, good afternoon, and good evening to all our IFSO members who have joined us for our October webinar. I'm Lillian Kell from Australia, and I have the pleasure of moderating this webinar. Our topic for discussion today is therapeutic options for recurrence of weight and obesity-related complications after metabolic and bariatric surgery. Now, this is a recent IFSO position statement published in Obesity Surgery, and the lead author for this paper is Dr. Ashraf Haddad. Dr. Haddad will be presenting. He's an accomplished surgeon in minimally invasive, advanced GI and bariatric surgery at the Gastrointestinal, Metabolic and Bariatric Surgery Center in Amman, Jordan. We also have two distinguished surgeons acting as panelists with us today. It is with pleasure that I welcome, firstly, Professor Michelle Suter from the Riviera Chablais Hospital, Rennes, Switzerland, and the faculty of the Department of Biology and Medicine in Lausanne in Switzerland. I also have Professor Pauliina Salminen, who's a professor of surgery at the University of Turku and the Turku University Hospital in Finland. Now, the presentation by Dr. Haddad will be launched shortly. Following the presentation, there will be discussions, and I invite all attendees to send in their questions on the chat line so that we can do a discussion on all your questions. I also like to remind all attendees that this presentation is recorded and will be available on the IFSO YouTube channel as well as the IFSO Virtual Academy online. So over to you, Dr. Haddad, with your presentation.
Dear friends and colleagues, thank you for being here today. I want to thank IFSO for the opportunity to present in this webinar. And before we start with this new exciting position statement, I just want to say that this position statement is the produce of the collaborative efforts of a large group of members that came out with this statement that I hope everyone would find beneficial in their practice. Now, just allow me a minute to share my screen, and then we'll start. This new position statement is called the Therapeutic Options for Recurrence of Weight and Obesity-Related Complications after Metabolic and Bariatric Surgery, the IFSO position statement. As you could see, huge amount of work and large number of the IFSO member community contributed to this position statement. We know that the obesity as a pandemic has been growing steadily, especially among children and adolescents. With the growth in bariatric surgery, we should expect a growth in the need of revisions, whether to manage the recurrence of weight gain or to manage complications. Now, this position statement is very long and very detailed, so I'm just going to go throughout the highlights of it. Now, recurrent weight gain after metabolic and bariatric surgery. We know that MBS is the most effective method in achieving sustainable weight loss, with the recurrent weight gain is a serious concern with all procedures. But the Obesity Medicine Association defines obesity as a chronic relapsing multifactorial neurobehavioral disease. So we should anticipate that multiple treatments or interventions will be needed throughout the patient's life. If you look at the IFSO worldwide survey, there's a rise in bariatric surgery procedures. Sleeve is still the most commonly performed. Roux-en-Y has been there and performing steadily throughout the year. And now there's a rise in the one anastomosis gastric bypass. And there are multiple studies, whether the Swedish obesity study, the study published by Wendy King and colleagues, Ted Adams and colleagues, that look at the long-term outcomes of bariatric surgery. So the Swedish obesity study reported that maximum weight loss happens at 1 to 2 years post-operatively. And then there is an element of recurrent weight gain, but patients seem to stabilize at 8 to 10 years. And that seems to be their weight they stay stable on afterwards. And the rate of the recurrent weight gain is usually highest after the year where they reach their nadir weight or their lowest weight. Adams et al. In their study said that 93% of the Roux-en-Y patients maintained 10% of weight loss at 10 years and only 1% regained to the original weight. I'd like to talk about this study, which compared bariatric surgery patients who underwent just surgery compared to those who had surgery and intense lifestyle modification to look at recurrent weight gain. And this was a randomized clinical trial. So looking at the two groups, the lifestyle intervention group had meetings over 2 years with focus on healthy diet, physical activity, behavioral strategies. And interestingly enough, recurrent weight gain was present in both. So sometimes as physicians, as surgeons, we tend to blame the patients once they regain the weight after our procedure, but this is not true. And the only thing that seems to prevent the recurrent weight gain is physical activity greater than 150 minutes per week. If you want to look at the factors or modifiable factors associated with weight regain, this is a systematic review of 22 studies, and then they reported 4 main modifiable factors: dietary habits, including alcohol, behavioral, psychological issues, lack of support, and physical inactivity. So our interpretation of recurrent weight gain, even in the literature, seems to be pointing towards the patient behavior. But we know that the disease is more complex, and there's central nervous, hormonal, and genetic factors that govern these behaviors. Now, once we wrote this position statement, we looked for the definitions of recurrent weight gain in the literature. And Wendy King and colleagues looked at 5 measures of recurrent weight gain. It could be weight in kgs, and this is what they found in the literature: BMI, percentage of pre-surgery weight, percentage of nadir weight, and percentage of maximum weight loss. But when do they become clinically meaningful? And you will find in the literature multiple cutoffs: weight in kgs, mainly 10 kgs, BMI greater than 5 BMI point of regain, percentage of pre-surgery weight if there's regain more than 10%. If you look at the nadir weight, some publications and authors will define it as greater than 10%, others is greater than 15%. If you look at recurrent weight gain as a percentage of maximum weight loss, there's multiple cutoffs: greater than 10%, greater than 20%, or greater than 25%. But all 5 weight regain measures or recurrent weight gain measures seem to be related not only to weight, but to the progression of the medical illnesses associated with obesity. And if we want to look at recurrent weight gain or insufficient weight loss definitions in the literature, we came up with this table. There are multiple metrics, as you could see, with multiple thresholds and multiple time intervals. This is why we cannot combine our data together to come up with one meaningful, let's say, meta-analysis to look at the outcomes of one procedure. And definitions should be key now in 2014, so that when we as authors report, the reporting is standardized worldwide. And here comes the importance of the IFSO consensus on definitions and clinical practice guidelines for obesity management by Dr. Paulina Solomon, who's here with us today. So it was briefly 3 rounds of Delphi, including surgeons, endoscopists, endocrinologists, nutritionists, and counselors. And I'm going to focus on the definitions part. So suboptimal clinical response is someone who did not have adequate weight loss from the beginning or did not have the desired improvement in their medical illness. Late postoperative clinical deterioration is someone who has an initial response, whether for weight or for medical illnesses, and then the weight recurs or the medical or problem or the obesity complication recurs. Then, with the advent of weight loss medication or obesity management medication, how do we calculate the baseline weight? Because sometimes people come up on surgery. So anybody who's on anti-obesity medication or obesity management medication before undergoing MBS, who stops it at the time of or shortly after surgery, we use their baseline weight as the weight before the medication. If someone continues on the medication throughout surgery and after surgery, then their baseline weight is at the time of surgery. We have to understand the difference between conversion, revision, and reversal. Conversion is one procedure to another. Revision is correcting one procedure anatomically. Reversal is restoring a normal anatomy. And obesity complication should be used, not comorbidity. A suboptimal initial clinical response was defined as either total body weight or BMI loss of less than 20%, and postoperative clinical deterioration defined as recurrent weight gain of more than 30% of the initial surgical weight loss. Now, the aim of this position statement mainly is to discuss surgical revisions, and then we'll talk briefly about medication. Not in this lecture. In the position statement, there is a section addressing medications. Now, an IFSO task force was formed by IFSO scientific committee members and IFSO members. Then a document was produced. It was approved by IFSO scientific committee and IFSO executive board. Revisions are expensive. In the US, one revision for recurrent weight gain will cost up to $50,000 US. So let's talk about our gold standard, the Roux-en-Y gastric bypass. So this table summarizes the long-term outcome of gastric bypass in the literature between 5 and 11.4 years. And as you could see, multiple definition of recurrent weight gain with multiple cutoffs. This continues in the rest of the studies. Again, hence comes the importance of standardization. You could see people defining it as 10% of nadir weight, or as a percentage of nadir weight, or as 25% of nadir weight, and so on. The sleeve gastrectomy, I looked through the literature. There is, these are the only studies that report weight loss outcomes of sleeve gastrectomy at 10 years. And the weight loss outcomes in those patients, obviously who remain non-converted, ranges between 42% and 70%. But the number is small, probably less than 400 sleeve patients if you look at them worldwide. And the recurrent weight gain has been described in at least 10% of sleeve patients. It's been described in some articles to contribute to 1/3 of overall sleeve revisions. And Roux-en-Y gastric bypass seems to be the most commonly performed procedure for revisions. Now, when you want to operate on someone for recurrent weight gain, you need intense preoperative workup. You need lab tests, upper endoscopy, imaging studies. You do not need to go into the case and be surprised by anatomy. It should be defined preoperatively. This is a virtual gastrography of someone who had like a missing sleeve. Look at the fundus. It's still there. And this is a CT scan of a patient. And if you look at the remnant stomach, there's contrast and there's air. So the patient has a gastrogastric fistula. So take your time to work up the patients before revision. And nutritional and behavioral counseling is key. And there's a section commenting on how you should prepare the patient from those standpoints. But you have to manage the patient's expectations. We all know that a revisional procedure will not induce weight loss similar to a primary procedure. So you have to address the patient's expectations very well. Look at their finances, socioeconomic status. Can they afford vitamins? You cannot do a DS on someone who cannot afford vitamins, alcohol and smoking, etc. And now, I'm going to briefly, really quickly go about the management options of recurrent weight gain after Roux-en-Y gastric bypass. Changes in the original, anatomy can cause recurrent weight gain. And the way we address them, is that we have endoscopic options or we have surgical options. Let's start with the endoscopic options. There are multiple systematic reviews and meta-analysis to look at the endoscopic options. We have the one by Brunaldi and colleagues and one by Vargas et al. If you look at these studies and these systematic reviews meta-analysis, the most effective way is argon combined with full thickness suturing. However, these ways will only provide a weight loss of 7 to 8 kgs, and we only have follow-up of 12 months. So if someone comes to you and they want to seek endoscopic options, argon with full thickness is the best option. However, the weight loss is limited and the duration or how the weight loss behaves after 12 months remains unknown to us. After that, we look at the surgical options for Roux-en-Y gastric bypass. There are multiple systematic reviews and meta-analysis looking at this, and here are the options. Placing an adjustable or a non-adjustable gastric band, i.e. banded procedure. This seems to give excess body weight loss between around 47% at 1 and 3 years, which is okay, not bad. If there's a gastrogastric fistula, it has to be corrected. Revising the pouch, doing like a sleeve of the pouch and the gastrojejunostomy is not really effective alone. You have to add something else to it. Conversion into a sleeve in preparation for a SADIS or DS is the most effective but very complex procedure, high complication rate, with excess body weight loss of 63% and 76% at 1 and 3 years. Finally, distal Roux-en-Y gastric bypass, similar to the paper reported by Kelvin Higa and colleagues, where you form a 100 centimeter roux and 3 centimeter common channel, seems to be a very effective procedure and safe, less complication rate than conversion to DS, obviously less technically demanding, with 54 and 52% excess body weight loss at 1 and 3 years. The distal Roux-en-Y gave the greatest decrease in BMI at 1 year. At 3 years, the greatest BMI decrease obviously was after the SADIS, followed by distal Roux-en-Y, followed by banding. The least effective were pouch and GJ revision techniques. At 5 years follow-up, distal Roux-en-Y had the highest BMI decrease. Now, let's talk about management for recurrent weight gain after sleeve. Recurrent weight gain is fairly common after sleeve because results are different and the procedures performed were different. We had issues, obviously, like all the other procedures, collecting and coming up with meaningful data. And then most data comes from small series of 50 patients or less than 100 patients. Now, a lot of people report on conversion into Roux-en-Y gastric bypass, but if you convert to Roux-en-Y gastric bypass, you should consider a longer BP limb Roux-en-Y. A standard Roux-en-Y might not be a very good option. And multiple studies mentioned that you need a BP limb of 150 to a 200 if you're doing Roux-en-Y after the sleeve for recurrent weight gain. The longer your BP limb, the higher the risk of nutritional deficiencies. Conversion into OGB seems effective and safe. It has a higher incidence of reflux and bile reflux and PPIUs compared to Roux-en-Y after sleeve gastrectomy. Conversion to SADIS or DS, I mean, you need a good sleeve with no stricture or twist and no reflux. Obviously, they are the most effective, but there is no long-term data on weight loss. There's a good long-term diabetes remission and should be a very good option for recurrent weight gain after sleep. You could see this is the studies. Finally, standardization of reporting is key, so outcome can be compared and data can be pooled. Before any revisional bariatric surgery, we need a multidisciplinary team approach. We need a full workup, imaging studies, preoperative lab, collaboration with our colleagues, the psychologists and dietitians is key. Surgical revision options are tailored based on the primary procedure as well as the patient profile. Finally, there's a whole section on anti-obesity medications or obesity management medications, which has become a very good tool in our disposal that could be used to manage recurrent weight gain after surgery. Thank you so much, and thank you for having me in this webinar. I will stop here and leave the discussion with you. Thank you.
Thank you very much, Dr. Haddad, for a very elegant presentation. You so rightly emphasized that a multidisciplinary team is essential within any bariatric practice, and more so for the evaluation of all patients who have recurrent weight gain or for those who do not achieve their desired clinical response. Now, however, the anatomy of the primary surgery can also be challenging. And you correctly said there are various methods that you discussed, such as endoscopy or surgical management to correct the anatomy. So how would you advise a bariatric surgeon which pathway they go to advise their patient? Now, there are many tests that has to be done. And when the results come in, do they go on a surgical pathway or an endoscopic pathway? Would you like to elaborate on that?
So it's a combination of what you find on imaging, what you find once you counsel the patient, the psychologist, the dietitian assesses them. But what I do, if there is something grossly abnormal in the anatomy of the primary procedure, like that large fundus of the sleeve that I showed an image of, that needs, I think, surgical correction. Now, endoscopic techniques for revision seem to have very poor weight loss data in multiple systematic reviews, and only they give around 8 kgs weight loss. And the funny part is, it doesn't matter if you do the pouch revision laparoscopically or endoscopically, they still remain the poorest of all techniques in regards to outcomes. The way or what I do, I speak to the patient. If they've been lost to follow up, we have sort of a back on track program where they meet with the dietitians, psychologists, look if they have developed not just bad habits, but if we wanna revise someone, let's say to a distal Roux-en-Y or a SADIS, then you better be sure that this patient will be compliant to follow up, not to instructions, that they will take their vitamins, that they will not disappear and come back malnourished. So we go through these steps and then we sit with the patients and we say, well, we could do, let's say, medications. We don't do, and I do not do endoscopic procedures for revisions, or we could do surgery. Some patients would say, you know what, I don't want to do medications. I want something more permanent. Some patients say, no, I would rather try the medications before I embark on another major surgery, especially that I tell them that the weight loss outcomes of the revisional procedures are not always as good as a primary procedure.
Thank you. There are some questions coming in. One of the questions is, do you have any data on nutritional deficiency evolution after conversion of a sleeve to a Roux-en-Y or SADI for weight regain?
So we didn't look at that question in particular in that position statement, the nutritional values, but we all know once you go to a distal Roux-en-Y, longer BP limb, OAGB with a long BP limb, or SADIs, you're at a higher risk of nutritional deficiencies. But the exact traits we didn't look at. I'm not aware. Maybe Dr. Solomon or Dr. Suter could help with that question.
Well, I'm not aware of specific data after conversion to distal Roux-en-Y or SADI, but you should expect the same number of nutritional deficiencies than you see after these procedures done as a primary procedure. I think the most dangerous procedure in terms of nutritional risk is the old kind of distal gastric bypass, where you have a very short common channel. And this has repeatedly been shown to be dangerous and shouldn't be done anymore. But if you remain with the advice by the group of Gassi and Higa, where they advise to keep a total limit limb length of 400 to 450 centimeters with a common channel of at least 300, the risk is quite acceptable. And they had very, very, very few protein malnutrition cases with this technique. Of course, the micronutritional deficiencies are quite common, but they also can be easily prevented with multivitamins or specific supplementations, provided the patient is compliant and takes them.
Can I go back to maybe a more general idea? Because I think you very nicely in the position statement kind of go over the fact that we don't really have an algorithm, as we don't have really standardized definitions, and we really don't know what we're actually talking about when we talk about recurrent weight gain and suboptimal initial clinical response. And there is one question about that too, because you showed the data that we agreed on. That was a consensus definition, and we all identify the problems of a categorical variable, because if you previously said that over 50% of percent total excess weight loss would be good, so 49 is bad, and everybody of course understands that that's not the case. And of course we need to start using percent total weight loss, which I think I answered already online. But my question is for the algorithm, because you did talk about obesity management medications, and I think this is because I'm sure all the surgeons get the same questions, and we do see a bit of a decline in the bariatric surgery procedures now with the very potent OMMs. And I think that's just a temporary glitch, because I think the key issue is that as we are only treating 1 to 2% of patients that would be eligible for the treatment of severe obesity and metabolic bariatric surgery, I think this tool just keeps on bringing more people within the active treatment. And for the primary procedures, I'm not worried at all, and I'm not even worried for the revisional ones. But for the algorithm, would you say, Ashraf, that OMMs are kind of the first line prior to revisional surgery? If we're not discussing any complications, we're solely discussing the issue of recurrent weight gain or suboptimal initial clinical response. So what would your take on that be? Would that be the first part of the algorithm? Because I think we also need to educate surgeons to be able to use the medications themselves.
I agree. It is an important part. The first part for a lot of patients. So let's say if someone who does not have a gastrogastric fistula, does not have
not complication, just
yes. And what I do now, I found myself using obesity management medications even early on after revisions. So I do not wait or let the weight stabilize at 1 year. You're doing a revision for someone with a very high BMI, greater than 50, greater than 60. Sometimes you do a SADIs with a 300 common channel, and at 4 months, they're not doing well weight loss wise. And there's nothing more surgical you can offer them. I've become sort of more brave in using these medications early on after revisions. Furthermore, for the people before revisions now, if they are not interested in surgery, or if now they come early because people are getting more educated. They're like, oh, I've already regained like 10 kgs. I don't want to wait to gain more weight or go back to my original weight. It's hard to tell a patient go to diet and exercise without offering them a little bit more help. I mean, I've been trying to lose 5 kgs diet and exercise for a year. It doesn't work. So I have been using them.
And I think this is what we need for the algorithm wise. I would say that maybe the OMMs would be our first step before considering extensive revisional surgery. And you can, as you nicely portrayed in your presentation, that all the work that you have to do before you do the revisional procedure. So you can actually start the OMMs and then start looking into making sure that there's nothing there. But I think this is a key issue that we have to keep in mind. So we have to have all tools in the box in our hands too.
If I may add, I think OMMs can be a very good solution, but who pays for it? That's one question. In Switzerland, it's not reimbursed in patients who already had a bariatric surgery. That's for one. And then I think before we start on medication, we really must make sure there's no problem associated with the procedure. With the huge funding pouch like Ashraf showed, I think that's not the case for OMMs. That's clearly a case for revision. Now, if in the patients who have no anatomical defect, probably OMM is a good option to start with, but we need to find a way for it to be paid for. But because
I fully agree on the workup, because of course you have to know what you're treating. And if we know we're just treating the weight loss and not complications, then I would consider it, and I would think about it. And the cost is a different issue. I think it's very interesting because now you have these cost analysis for the primary procedures that will say that metabolic bariatric surgery actually becomes cheaper than the medications in a year. But again, maybe I'm hoping in 5 years the medications also will be cheaper. So access to medications and also bariatric surgeries, they're both key issues. But this, I think, has to be kept in mind for the revisional procedures.
I'm just looking at the questions coming in. There is a question asking, what is the best revisional surgery after a Roux-en-Y gastric bypass for refractory GERD, but success of weight loss?
GERD and weight loss?
Good weight loss, but GERD.
You want me to take that one?
Go ahead, Dr. Suter.
Yeah. I mean, GERD after gastric bypass is uncommon, but it happens. Between 5 and 10% of the patients, sometimes a little bit more. Most respond very well to PPIs, but there are these few patients who do not respond. And in these patients, you can either use a LINX if you have it available. I'm not a believer in that technique. It seems to work, but I'm afraid in long term we'll have many erosions with this. Another good option is to reoperate on the patient, correct the hiatus hernia, do a hyatoplasty, and do a kind of a Nissen with the remnant, and that works very nicely. So I think this is the best reoperative option for a patient who has good weight loss and GERD after gastric bypass.
I'm just reading some of these questions. There is a question about cautioning against distalization, but does anyone have any idea about the function of the pylorus after sleeve and after GPD? Anyone like to answer that?
Sorry, I didn't get the question. They're asking about the function of the pylorus.
That's right. After sleeve and after gastric bypass distalization. I think this question is.
I mean, The reason is if we have an intact pylorus, we could probably have a shorter comment channel because we assume that the pylorus would slow down the transit of the food into the small intestine compared to a regular gastric bypass or a one anastomosis gastric bypass, if this is what the question is.
All right, if the person would like to elaborate the question, please go ahead, but I'm just looking through the questions. We are covering a lot of and there are a number of questions that are overlapping, particularly on the OMMs.
There's Lillian, there's one on the if we're aware of the insurance reimbursement for the recurrent weight gain. I don't think so, because even the primary treatment with OMMs is not covered within most systems. I think the data actually shows that the majority of patients, so I think it's about 90% that pay out of the pocket. So this, of course, is not, there is a clear issue on not all patients being able to use the medications.
I think even in Australia, the medications are also very expensive and not covered, and they are covered by their own, by their self-reimbursements. There's a special greeting to Professor Suter from one of the attendees.
With a very good question also.
That's right. The question is, if you have a total weight loss of less than 20% after 18 or 24 months, but almost complete resolution of comorbidities, would you consider an MBS a failed one? We need to judge the results globally and not focus only on the weight loss. So is there a time frame period beyond of what we estimate that revisional surgery is needed for failed primary surgery? And if how long should you wait?
Well, that's an excellent question. I think, yes, we should look at weight loss. We should look at resolution or improvement of comorbidities. We should look at quality of life and patient satisfaction. I mean, there are patients who lose 25 or even 35% of their weight starting at 200 kilograms and remain with 130 or 140 kilograms, but are very happy with the difference. The diabetes is gone, the hypertension is gone, and can you really expect much more weight loss with reoperation? Maybe so, but at which risk? So I think we need to take into account the global picture. The patient is happy with 18% weight loss. And again, this is just a cutoff. Is 20.1 better, much better than 19.9? I don't think so. So we need to look at the entire picture. Is the patient happy with the weight loss? Are the comorbidities or the complications improved? Is quality of life sufficient? If the patient is unhappy, the comorbidities are still there, he or she really wants to lose more weight, then I wouldn't expect 5 or 10 years, but I would really go back to the multidisciplinary team, because many of these patients still have nutritional or dietary issues that need to be addressed before reoperating. If they eat the wrong way, the wrong things, and keep doing that after revision, we won't have good results either. There are factors that are not modifiable, like the genes, the neurobehavioral factors, but we may influence how the patient responds to these triggers, and teach them to not necessarily eat every time they feel they are hungry, but try to figure out other ways to cope with these triggers. But
I would really
no time limit for me to start discussing revision if the patient requires it and clearly the results are suboptimal.
I would really strongly echo what Michelle said, is that we really need a composite endpoint. Of course, we can't look at just the weight loss. We need to look at the whole picture. But one thing as a terminology wise, I would say that please never use the word failure. in literature or with patients, so it's not a failed procedure. So and using the categorical variables, and I know we were part of the consensus that we had a very vivid discussion, and I replied to one of the questions is on how to define the threshold. And as Michelle said, again, it's like the categorical variables are very tricky. Of course, it would be great if you would have just a continuous variable, but we need to have something in order to, have comparable studies. So we would eventually end up in an algorithm based on actual evidence-based data and not opinion. So that's why we need comparable results. So I would say, and when you look at the consensus we did in Hamburg for the time frame, even though it's not absolute, but of course the weight nadir will be around like between 1 and 2 years. So the idea was maybe to wait like up to the weight nadir around 2 years. And again, we're discussing not complications, only suboptimal initial response or recurrent weight gain.
Yeah, we must also know that about 10% of the patients reach their nadir much longer than 2 years after surgery. So there is, for many patients, there's quite a lot to do in terms of behavioral therapy or dietary counseling, or even increasing in physical activity before we really can decide that the result is suboptimal. Sometimes it's 10 years after surgery that they get to their best result.
Coming back to the revisional surgery, there's a question about converting a gastric bypass to a sleeve. And the question is, how does the sleeve react? Or what happens to the pylorus? I guess going back to the original question.
Yeah. Can I take that one?
Yes,
Sure.
of course.
So if you reverse a bypass into a sleeve, or let's say a bypass into a normal anatomy for that matter, I always do an intraoperative endoscopy to look at the pylorus, because if the vagus nerve was sacrificed during the primary procedure, the patient will have an element of gastroparesis and he will have symptoms. So what I do, and we did this probably more than 10 years ago when I was still a fellow with Dr. Kelvin Higa, we used to do an intraoperative endoscopy on every reversal, whether to a normal anatomy or conversion into a sleeve. If the pylorus was tight, we always added a pyloroplasty at that point. Now, otherwise, if you reverse them to normal anatomy and they end up with gastroparesis, you have to go back and do the pyloroplasty then. So I'm not sure how much difference it will make into symptoms, but if I go in after I do the gastrostomy and I cannot traverse the pylorus with the endoscopy easily, I add the pyloroplasty. I don't know what the rest of the panelists think about that.
Well, I have no experience with converting a bypass to a sleeve, so no answer. But I would believe if the vagus nerve was preserved when doing the bypass and is still preserved when doing the sleeve, then the pyloric function should be approximately normal.
Yes.
Whereas if you cut the vagus nerve, that means you start cutting your stomach from the pos laxative, then you obviously cut the vagus nerve and then you may have problems. But this is theoretical. I have no experience.
Yeah, me neither, but it would be a very rare case in this. But I think this is exactly what on a theoretical basis you would think that happens, but not very common, I would say.
It's not a common conversion. I've only done
No.
one. It seemed to go all right. That's all I can say.
That's bypassed into a sleeve.
Yes.
Yeah, I don't do them, but the pylorus part applies more once I reverse the bypass, because I still have to look at the pylorus. I guess people, I think the original paper by Dr. Hempens looking at the complication rate of reversing, doing a gastrostomy, it showed a high leak rate, maybe 12 or 20%. I do not remember exactly. So this is not something to be taken lightly.
So the next
No, and
question
no, I was
is,
gonna just comment on that really is an issue when if you reverse to normal anatomy again after Roux-en-Y gastric bypass. I think that's markedly a more even though that's not even that common, but still that's much more common than the previous example.
Yes.
so anatomically, the question is, if you've done a pyloroplasty, can you still do a SADI-S?
Who's writing these questions? I mean, I have no experience with that. I've never encountered this. To me, after looking at this position statement, there is excellent outcome with the distalization of the Roux-en-Y, which is just one small bowel anastomosis. You divide the rudum and take it distally. I see, super nice videos in conferences about conversion of a Roux-en-Y into a SADIs. I personally do not do that.
Now, if I may add, one of the advantage of SADI-S over OAGB is that by preserving the pylorus, you prevent bile reflux and pancreatic juices reflux into the stomach. Now, if you've done a pyloroplasty, this advantage is gone. So I would submit that doing a SADI-S after pyloroplasty will lead to quite a lot of bile reflux into the remnant. Will that be of clinical importance? I don't know, but it certainly probably will be a disadvantage for the patient.
Lillian, there's a question about recurrent weight gain after BPDDS or SADI-S. Any suggestions? I don't think.
Yeah. Want to take that, Dr. Purina, or?
Sure, no, go ahead.
We couldn't find any evidence in the literature. There's no reports on the recurrent weight gain after the traditional DS or the SADIs. And if you want to look at the outcomes of DS or SADIs, once they're offered as a second stage procedure, the data is even more rare. So I don't think there is anything in the literature. The only thing I could think of is maybe shortening the comment channel even more, or just going in, making sure it was counted correctly at the SADI's time. But other than that, I have no sort of surgical options. Here comes the obesity management medications. It's in these cases, I guess.
That's what I was gonna say. I think that would be, in that case, the first option, because if you really go, as Michelle said, that you do, it's a very short comment channel, then you actually it's a trade-off. So you're really, if you're getting more weight loss, but then again, you are getting more nutritional problems, which eventually can actually be quite bad. So I think this would definitely be a case for the OMMs.
well, there's an interesting question about what is the recommendation for stopping GLP-1 receptor OMMs prior to bariatric surgery?
This was actually, we discussed this quite a bit also during the last OMM consensus, and the data is not really that clear. I think the majority of places recommend 2 weeks, or some even 1 week. I don't know what is the recommendation in Australia or Jordan or Switzerland.
Well, I guess it's a 2H question in that, are you referring to the effect of the GLP-1 receptor on gastric emptying, or do you want to continue the effects of the cessation of appetite while you go on and have bariatric surgery?
I thought that would actually be based on the kind of the idea of what would be the safety time to stop the medications. That's how I understood.
The recommendation to stop before surgery comes from the anesthetist. Who want the
Definitely.
stomach to be empty when they induce anesthesia. And I think this recommendation does not have anything to do with the results or the expected results of surgery.
No,
It's a
only
clear
anesthesiologist.
then it can be stopped before surgery and restarted after surgery if you want. But the current recommendation is to stop before surgery to prevent aspiration during induction. The data behind this is not very high, very clear, but these are the recommendations in most patients, in most countries,
Yeah, 2 weeks for, at least for us.
at least for semaglutide.
Yeah.
Probably shorter for liraglutide.
Yeah, because the half-life is much shorter. Yeah.
Well, we've been doing 1 week and we have not encountered problems.
I think that's probably more close to clinical truth. I think the 1 week, that
Yeah.
would be sufficient.
Um,
There is a question about body composition. Somebody is doing a very interesting PhD, so we will really wait for those thesis results, looking at the body compositions, kind of assessing what would be their goal. And I think that's raising a very nice point, because the discussion with the patients should always, incorporate all of the aspects of the composite endpoint, because sometimes the patient also maybe a bit focused on the weight loss, and it's really crucial that they have a realistic idea of what can be achievable when you do the revisional surgery. I don't know, Ashraf, did you want to comment on that one?
Sorry?
Kind of the expectations of the patients
Oh,
when they
yeah.
think about with
Patients.
it, because I think that's very crucial that they have a realistic idea, whatever the means is that we're trying to further help them.
So I think we all know that once you sort of the best chance is with the primary procedure. The more revisions you add, you have no way of accurately predicting the weight loss if this is what the patient is seeking, or even the resolution of their medical illnesses. The psychologist who helped with I think Dr. Grothi, Karen Grothi from Mayo, who helped with the writing of this position statement, highlighted the patient expectations and highlighted that, and I changed myself after writing this position statement. Now I tell patients that come for revision, well, we expect you maybe to lose this much, but we're not sure, because with the primary procedures, we have better data or a better mean, or you're going to lose 75% excess body weight at 1 year. We do not have that with revisions. So it's their right to be well prepared and well informed before embarking on a third or fourth revision for weight loss. I think this is important.
I fully agree, even before the first one. So to have a realistic idea of what to expect after the procedure, or then also whatever you use, even the medications, as the response, the individual variability of the response is very huge, based, of course, on the heterogeneity of the chronic disease of obesity. So we really don't know. So I think they need to be aware of this.
I think it's very interesting that we don't talk just about weight and amount of weight loss. I mean, the comment here, using fat mass, fat-free mass, I think that will be, a better way of assessment of the progress of patients. So I'll be very interested to see the PhD results of this, of one of our attendees, because we do agree weight is not just what it matters. It's a composition and the distribution of fat and muscle and and all that. So thank you. We'll look forward to the PhD results.
And that's before any other questions come up. Because that's exactly why we aim to do the kind of improved Barrow score by combining the large RCT data with the Swiss colleagues. is that we came up with the SF-Barry score, which is far from perfect, but it's like currently the as simple as possible, trying to, combine the weight loss, the for essential comorbidity remissions and complications, because that's the data everybody needs to have if they're doing metabolic bariatric surgery. So a comparable composite endpoint, I think we really should try to use something like that. And I'm really, of course, hoping that this will be one of the solutions that help. And this would actually be my question to Ashraf as the first author, is like, how would you think about implementing? Because now we've done our standardized definitions from the Hamburg Congress. We now have our OMM consensus on that we did in Vienna, which I think all of are great. Now we have this position statement, and I think these are all very necessary. But again, if we just have it as a paper in the journal, we need to implement these in clinical practice. So what would your idea of implementing? Because I think the implementation of all of these issues really that's a whole lot of work, and has to be done on multiple frontiers. So what would your comment on that be?
Okay, I mean, thank you. Very hard question. So here's I did mention the consensus specifically during my presentation because any physician or surgeon that treats obesity needs to be familiar with the terminology and definitions. This is the first step, or otherwise we will continue to use different language and we will continue to report different outcomes and we will never be able to pool data. And I think there's part of the responsibility is on the surgeon and the authors to familiarize themselves with these definitions. Then comes the role of IFSO in raising awareness between members. Then comes the role of the journals, obesity surgery. You know what? Unless you report recurrent weight gain according to this, unless you report suboptimal clinical response according to this, we have I mean, now when we review papers, we send them back saying that the author did not use patient's first language. And we should do the same with these definitions. I think the following step, because these three position statements are interrelated. In a few years, if we have enough publications about revisions, let's say revisions of Roux-en-Y, using the same language, then we'll be able to come with a good systematic review meta-analysis on the outcomes of distalization or on the outcomes of a banded procedure. So I think addressing the surgeons, if so raising awareness, then comes the role of the journals.
I could not agree more. I think all of those three components are crucial, and I fully agree. And this is also a matter of other journals. So I do confess that I've sent the list out to a few other journals that I work for. So just to make sure that they actually start using it, because this would really be, as you said. So with this, we're hoping to have enough evidence-based data so we could actually think about perhaps looking at it also in a more controlled randomized trial when we have the basic idea what's happening, which we currently don't because of the variation of the different definitions.
I may add, maybe for us to get more information about the results of therapies, surgeries, or whatever done for recurrent weight gain, probably registries here have a major role, much more than for primary surgeries, because many of us do have large series of primary surgeries, but we do only a few revisional cases a year, especially with the different types of revision. So if you pooled all this data together in a registry, that will probably help us getting results at least at midterm and much earlier than
Definitely.
it individual.
And then also using, because for the registries, you could, as we did for the validation of the SF-Barry score, then you just combine the registries and then use the same definitions and alter the data. So you're actually able to do that. So I think we really need to work together on this by trying to combine as many patient cohorts as possible to get more reliable data.
I totally agree, and that's why IFSO supports national registries for each of the countries that belong to IFSO, and we certainly encourage anyone who does not have a national registry to set one up, and IFSO is certainly very happy to help everyone for that. I think it's time that we should wrap up. We've had a wonderful discussion about our therapeutic options. I'd like to thank Dr. Haddad for his presentation. I'd like to thank Professor Suter and Professor Salminen for their input. And I also like to thank the attendees for attending and putting in their questions. Just remember that this session is recorded. And for those who would like to go back or look at this presentation, it is on the IFSO YouTube channel as well as the Virtual Academy. So thank you everyone for attending, and we'll see you all next time. So have a good day or good afternoon or good evening, wherever you are.
Thank you very
everyone.
much. Thank you.